Imagine this. You're 38 years old, you have 2 kids already, and you think that you're done. You go in for your yearly checkup and you talk to your provider about contraception. They offer you several different types of pills, maybe the depot shot, condoms, but really nothing else. Fast forward 6 months and you have yourself an unplanned pregnancy. For women of advanced maternal age, 35 and above, this is not just a surprise, but this can be a serious health risk. Rates of complications like preeclampsia, gestational diabetes, miscarriage, chromosomal abnormalities rise significantly after the age of 35. And yet, in many rural and primary care settings, women of this age group are not being offered the most effective contraceptive options simply because their provider lacks the training or resources. Hi, my name is Brianna Dumas, and I'm a nursing student with Eaglegate College. My capstone project is empowering primary care providers to expand LARC access through structured training. Women ages 35 through 50 in rural areas face barriers in accessing long-acting reversible contraceptives, or LARCs. This project uses provider training, patient-centered counseling measures, and EHR audits to improve LARC counseling and access. The goal is to increase provider confidence, patient satisfaction, and equitable contraceptive care in underserved communities. In Idaho, approximately 32% of the counties are considered maternity care deserts. These areas lack adequate access to hospitals, birthing centers, or sufficient maternal care, such as OBGYNs. For women, especially those of advanced maternal age, this limited access can delay time-sensitive reproductive decisions and care. Long-acting reversible contraceptives, or LARCs, such as IUDs or implants, IUD stands for intrauterine device, those require specialized training for both insertion and removal, and these procedures are most often associated with OBGYNs, but they can definitely be done with a primary care provider with the proper training. Primary care providers are essential for bridging this access gap to rural and underserved areas. My research question for this project was, how does structured LARC education and hands-on training compare to no formal training in increasing LARC counseling and prescribing? In rural areas, lack of training equals fewer providers comfortable with insertion and removal. And this gap negatively impacts reproductive health, especially for women of advanced maternal age, where their risk of maternal complications is elevated. This project focuses on women of advanced maternal age between the ages of 35 and 50 who are living in rural communities and receiving care in primary care settings. This group often faces challenges, higher risks during pregnancy, but also limited access to effective contraceptive options like LARCs. By focusing here, we're addressing the population with both high risk and underserved. For the sample, we look at women meeting these criteria that are already patients who are participating in rural clinics. To support this intervention, we're going to use several key instruments. The Person-Centered Contraceptive Counseling Measure, or the PCCC, is going to help us gather patient information about the quality of their counseling. We're also going to use EHR systems, or electronic health records, to track how often LARC counseling and insertions were documented before and after the provider training. Materials include educational modules from Beyond the Pill program. Not only do they provide provider training, but they're also providing clinic posters and hands out to support patient education, as well as structured counseling guides for providers during their visits, like the PCCC. For data collection, information came from both patient surveys and chart reviews. An analysis looked at trends in provider counseling frequency, LARC uptake, and patient satisfaction scores. Together, these tools give us both clinical and patient-centered perspective on how effective the intervention was. The theoretical framework for this project is guided by the Bandura social cognitive theory, which focuses on self-efficacy. Providers who feel more confident are more likely to counsel and insert LARCs. Learning happens through observation and hands-on practice. Improving provider confidence equals more patients having access to effective contraception. In my literature review, I found that research supports that women of advanced maternal age are at much higher risk of several different types of maternal complications. My research also showed that there are persistent gaps in LARC training. I also found that provider training increases LARC access. Research showed that providers are more likely to recommend LARCs as the first-line contraception after structured education. As a nurse, this resonates. Our confidence in performing a skill comes from seeing it done and practicing it ourselves. The intervention that this project would supply is providing that structured training to those clinics in rural Idaho. This would involve didactic sessions and hands-on simulation with LARC insertion and removal. There would be a pre-survey and a post-survey to assess the provider knowledge and self-efficacy. The goal is to improve provider readiness to offer comprehensive contraceptive counseling and expand LARC access for patients. The cost of this project should be under $2,000, where the majority of the cost actually comes from the providers stepping away from their practice for the training itself. The education materials would be provided by a company called Beyond the Pill, which provides both online and in-person training for IUD insertion and removal, as well as implants. Additionally, there is grant funding that can provide those education materials for free to clinics that qualify. For sustainability, EHR or electronic health record prompts would encourage counseling and documentation for patients that follow those certain parameters. And nurses can also champion this project by reminding providers to normalize LARC conversation in everyday care. I based this project off of several different studies that showed that training leads to measurable increases in both provider competence and LARC prescribing. One such study in rural Texas showed an increase in LARC access in all 3 clinics. Not only that, but there was an uptake in contraceptive counseling across the board. Data tracking would be through chart audits. You can see on my poster that there is a chart there that shows that pre-intervention there was no LARC access in that Texas study, and post-intervention there was an uptake. The proposed timeline for this project would be about 8 to 12 months. Ideally, the first month would be about engaging stakeholders. Second month would be data collecting. What are we doing prior to the intervention? Third month would be provider training. And then from then on out, it's implementation, data collection, and analysis. In this project, there is ongoing evaluation built in. This staged approach means that providers aren't overwhelmed and changes are happening progressively. In conclusion, structured education equals improved provider competence, more consistent counseling, and better patient outcomes. Nurses are essential advocates for this process. We bridge the gap between the providers and the patients. For women of advanced maternal age, improving access to LARCs is not just about preventing pregnancy, it's about protecting their health and reducing the risks associated with later age pregnancies. If we can give providers the confidence and skills to be able to offer the most effective contraception option, then we change the trajectory for reproductive health for so many women, regardless of age or zip code. This is not just a provider training initiative. This is a patient safety initiative. Thank you.